I'm actually honored to be here, and I definitely feel I'm amongst friends and colleagues in this world of what we do. And definitely, I think the emotional nature of it is so deeply true in so much. I had just got back from Ukraine. I was there on a mission with a watchdog organization called Disability Rights International, specifically to look at the care of people with intellectual and developmental disabilities around the world, and in Ukraine in particular. And I could speak all about that. And I think the emotional nature of living, working, caring for people in Ukraine in the context of coming here and speaking to you, it's really surreal in some way. And maybe after this, if people want to chat with me about it, I can do that. In what I wanted to do today, and my purpose really wasn't as much to focus on the therapeutics and the diagnostics, the care practices in some general way, but basically is really focused more on transitioning of care from pediatric to adult. And I'm an adult neurologist, and I do different leadership efforts around the country and in the world in some respects. And for those that in the audience probably do appreciate the care of adults with intellectual developmental disabilities is really kind of falls short in many respects. Transitioning is really difficult. And in my talk today, I really wanted to focus also on an individual and a person. That's Dawn. That had been my patient for many years. And throughout my minutes that I'm going to speak with you today, and get the electric hook to kind of pull me off the stage here, is I'm actually going to be speaking about my relationship with Dawn, and with Dawn and her family. Because I think there's so much that is so relevant. Let's see if I can get let's see here. Surprise, surprise that people with Dravet or any other intellectual developmental disabilities grow up. They're not always going to be young children anymore. And so when they grow up to become adolescents and younger adults and older adults, they will have their own issues and need care. And there's Dawn. I mean, there's Dawn and Diane, her mom, and her sister Danielle, and her father, and they had wonderful lives. I mean, they basically had wonderful lives, much as like it is for all of you and for people that you care and support, but challenges, the same challenges that anyone with Dravet or any complex neurologic issue would have. They definitely were having their issues. They were living their lives. I mean, they were basically living their lives, pushing through, pulling through, prodding through, trying to be optimistic and try to get through their lives. But seizures, as we all know, and certainly here with Dravet syndrome, know that seizures certainly have been very troublesome and problematic for Dravet. And the issues of Dravet is what you all know, and probably what you see and what you know. So I'm really not going to be saying too much different about what you know or what you see about Dravet in epilepsy. But these things, these difficulties, these challenges continue with the individual throughout their life. And the issues do affect quality life, and definitely for me as a physician, giving a lot of drugs for behavior, for seizures, for spasticity, dietary changes throughout the individual's life, and the invasive procedures for seizure control, which many you may be aware of, or your loved one may have instituted for them. Yeah, I mean, that is something that I pick up. So when I transition to me as an adult neurologist, these are things, these are issues that carry forth in the individual's life. The psychosocial aspects of living with epilepsy, with a developmental disability with epilepsy, are obviously quite significant. And all these things, I think, resonate. And I think these things, these issues, these concerns, are part of the life and the social fabric of everyone. And they are relevant. I mean, they should be very relevant to the healthcare provider. Certainly, all these issues, the quality of life, the value of self-esteem, quote-unquote value, a vulnerable child, and being careful of my loved one in their associated mood issues, ADHD, learning difficulties, and certainly what do all these drugs do, good and bad, adverse drug effects. Parental stress, I mean, I probably don't need to speak about parental stress for any, I mean, I have 2 children, my children are much older now, and definitely any caregiver can appreciate what it means to have your loved one, your child, that is having their own issues or concerns, but add on to that Dravet and the complexities that they may have and what that means. But as they age, and what does that mean for the caregiver? I'm kind of, I like these open-ended comments. What does it mean? What's the implication of all these things? And this is just the typical, trials of medication that everyone with Dravet or any other complex neurodevelopmental syndrome may have with seizures. This is, the gamut. And again, my purpose here wasn't really to base the therapeutic nature of my discussion. That's for other people to spend time. So yeah, I know that. So for me, picking up the pieces as an adult neurologist on individuals that have already been through this is something that we have to appreciate. This is kind of a slide that really talked about these challenges that are innate within the diagnostics and therapeutic care. The syndrome is very refractory to medication, especially Dravet and Lennox-Gastaut, multiple seizure types, status epilepticus, clusters, usage of lifelong epileptic drugs, and I mentioned polypharmacy. And side effects are always very difficult in someone with an intellectual disability who might be poorly verbal or nonverbal. How do we really know that they're having difficulties? The issue of diagnostic overshadow, I'm not sure if you guys know the concept of that, is basically when someone with a developmental disability is not acting right, or they're different or changed a certain way, is immediately blaming their underlying developmental disability. Say, oh, this is how people with Dravet act. This is from Dravet, rather than like being more open-minded, say maybe there's a toxicity or maybe there's some untoward other problems going on. The difficulties of data collection, communication, absolutely, and of course the transitioning, which is part of what I'm talking of. And there's this one little comment to the far right: all substances are poisons. There's none which is not a poison. The right dose differentiates a poison from a remedy. This is from actually a pharmacist philosopher back hundreds of years ago, and that's really the nature of any medication that we all take or give to people, that anything can cause harm to people, really. People with certainly Dravet and other forms of developmental disabilities certainly do have other associated difficulties: behavior, mood dysfunction, lung problems, swallowing problems, bone difficulties, nutritional difficulties, and I do specialize in aging, so I also see aging-related concerns, in particular those with Down syndrome. I'm a specialist in early onset Alzheimer's and Down syndrome. And aging with Dravet is I say it's new. I like to say it's new, but it's really probably different because the fact that people with Dravet are now living longer than ever before because of early intervention and the appropriateness of care and the therapeutics that are now afforded to people with Dravet and other kind of conditions. So they are living longer. They are presenting with lifelong seizures and medications I mentioned, but also I think there's changes that do happen with an adult with Dravet, which is really something that really wasn't known about as much before. And really the key, and I have this one little point, making the diagnosis of Dravet syndrome in particular, and this might come like, well, of course, they got Dravet syndrome, but let me go back to Dawn, the individual that I've been showing pictures of. She did not have a diagnosis of Dravet until 15 years ago. She had a diagnosis of a non-specific developmental disability, Lennox-Gastaut, and I had been taking care of her because when she was in her 40s. So by the time she was living her life back in the day, there was not a genetic diagnosis, and the idea of the change in genetics for Dravet wasn't even known about. So she started changing. So Dawn started changing in her walking and her cognition. She was having increased muscle tone, swallowing difficulties, and it became very obvious that there was a change at foot. So basically, I made the diagnosis finally after 35 years of Dawn living her life that she actually had Dravet. So it really put into perspective exactly, boy, she's actually had Dravet all these years, and this is kind of now makes sense about why she is what she is and why she's now developing these changes. The key also certainly was, trying to ensure that Dawn in her life, just as you saw in the photographs, that she was living her life and happiness and how that was with her family. And then for me, accepting the baton from the pediatric neurologist many years ago was for me as a physician to try to do good by Dawn and do good by her family. And the relationship with me and her family grew and grew and grew, and I became really good friends with the family. And my community support organization, the ARC, I'm an executive director or executive member of the ARC in our area, ARC, and I became very involved with that. And because of the fact that not only was Dawn was getting older, but mom and dad were getting older, actually, sadly enough, they went through a divorce. It was really challenging. They went through a lot of stresses, and then Dawn was changing. So there's a lot we were going through. This is kind of a busy slide, and you won't be able to really see it much of this. And basically, this is a busy slide that talks about changes in those with Dravet over the course of years. What are the things that in someone with Dravet may see at some point early in infancy in terms of their seizure types, in terms of their change of mental status, in terms of their walking, in terms of febrile seizures. And at the tail end, this is kind of, so I pick up this, most of it goes from age 16 and then has that little adult in the little yellow from 16 to 32. So I pick up, for adult neurology, we pick people up in the adult world. So we miss all these things. We miss much of those changes. And so I was picking up Dawn and caring for her when she was ready. I guess she was like 30-some years old. So this really does talk about the changes, and I think that's the important thing to appreciate in caring for someone with Dravet syndrome, is that there is a change that does happen in a percentage of people with Dravet. The transitioning is something that we in the adult world have been talking about forever, and one of my colleagues, Larry Brown, who'd been at Children's Hospital in Philadelphia, had helped put this out, and to support also with Child Neurology Foundation, a transitioning guide about what's the best way to enable the transitioning smoothly, safely, easily to transition from pediatric world to the adult world. There's no doubt there's a different culture between the pediatric neurologists in terms of their mantra or mission and what they do for people. The adult neurologists, basically, by and large, and again, this, you may know this if you work with adult neurologists, we're very singular in our purpose. We don't treat the behavior. We're not really as socially oriented. I'm being kind of facetious slightly in my comment, but basically I would say this is generally stereotype of an adult neurologist. So really there's a big transitioning of care that's really somewhat difficult because the culture is very difficult in what we do. The neurologists don't have the experience or training, and this is kind of what I do. So my role as the leader within the AN and ADMD is I'm the leader in trying to change these things and trying to change the experience of training. Time-consuming, complicated people, patients, reimbursement of care. So these are issues that are brought forth when people with Dravet are transitioning. Caring, I wanted to make sure in my last few slides, caring is a huge issue, obviously, that if you really don't care about the person as a person, then all the issue about genetics and pharmacologics and testing, all that really doesn't matter. So this slide is huge. I mean, this slide is very important about respect and caring for someone. And again, this might be, I guess not shocking. I mean, why should this be such a shocking thing? Of course you care. Of course you love this person, and of course you value them. Of course. But of course, does this really always happen? I mean, again, I won't point out to anyone in the audience and say, does this really happen? And I just got back from Ukraine. I mean, I could just tell you my own Ukrainian experience about what I saw, what I did, and what I believe. This definitely is not in Ukraine. This is definitely not in there in terms of all these things. It's tragic. It's really tragic. And the United States is certainly not perfect by no sense. So I'm not carrying the American flag on my lapel here, and I'm not, saying holier than thou, and look at us, we're great, we're great, we're great. We got a lot of learning and improvement in what we do. So this is my last few slides, and basically is what's the solution here in terms of going into and there's Dawn. I mean, there's Dawn hanging out. She's chatting with a caregiver, and she's living her life, hanging out, doing her thing. Basically, the expectation, truly, and this may come as, again, no shock, is the adult neurologists don't know. They may not know. This is community-based neurology. I'd like to think epileptologists and universities are going to know these things. But a lot of times, the care is being provided in a community. I'm a community-based neurologist where a lot of community care for most people, developmental disability is being provided. It's not always the so-called transitioning clinic or university centers. It's really the community. They may not know what Dravet is. The neurologist will look at this person and say, oh my God, they themselves are going to be like, oh my, what is this? Who are you? What is it? What you have? What? There's a big chart with all these drugs, and they're like, oh, and they're like, their eyes are spinning, and like, you can see the look on their face. I'm trying to be. It's really not funny, but it's almost ridiculous, I guess. Do they really understand about looking at the individual and say, I'm going to talk to Dawn. I'm going to talk to Dawn as a person with value, as compared to immediately talking to mom or dad or caregiver. I think you know this, right? I think you probably appreciate that work in the field and do know this. Do they really appreciate what mom or dad or the caregivers are going through at home? Do they really know? And especially if it's an aging mom or dad, what are they going through? And is it relevant? Damn, it should be very relevant. It should be very relevant. And the key is basically building the relationships, because certainly if you want to get best care practices, you want to be able to have the trust and relationship building with the caregiver, with the physician. So working really with the neurologist, they don't really have the experience. I think most of them don't. And I think the care provider, the family member that goes in is really almost like teaching them to be a better doctor. And this is kind of my take-home message, is helping them to be better. Making and saying, and almost like assuming they're, I would say ignorant, that's not the right way to put it, assuming they don't really know much about it, and almost like holding their hand, literally or otherwise, about trying to love and care and support their loved one. That's who they, because this is who they got. There may not be other, specialists in their area, which is really true. And feeling comfortable as the advocate, the family member or health support person coming in, is feeling that it's a team building exercise as far as I'm concerned. And I really think it's very important to even start out with that conversation, even like lay it out, like lay your soul out in some way and really talk about this, because you have to build these alliances over time. There's no doubt that the immediate need of the healthcare provider is to refill medication, do blood testing. There's no doubt there's immediacy that has to be done. But the key, I think, initially is build the bond. I just think I can't overstate the importance of that. Organizations like Dravet Syndrome Foundation, and I'm affiliated, and there's a whole bunch of labels here. And so what I've done is I build bonds, I build relationships, because I really think it's like building a home, building a team of a lot of people. So Dawn, Dawn had lived a rich life. She had her challenges, she had her difficulties, but Dawn progressed. Dawn had more gait dysfunction, swallowing dysfunction, and with the diagnosis of Dravet, the family appreciated that as Dawn was living, that her life was valuable, but also the challenges that lay ahead for her were becoming more difficult. So Dawn, after some number of years, went to basically a wheelchair, and she had some swallowing difficulties and had to get a feeding tube, and Dawn passed away 2 years ago. Thank you. I did not look at a clock. I did not look like, I have no idea. I just kind of threw my words out there, so I don't know if I had questions, answers. I don't know if I should apologize for my diatribe into the personal nature, but I really didn't think of how to do this presentation any other way but making it a very personal discussion. I know this probably comes as no surprise. Is there a question? Can I get out of the spotlight? I'm probably going to get in trouble. Is that a thumbs up? All right, I'm coming out of here. Oh, you can? Well, I'm like getting like a sunburn here. Hello there. And who are you? I'm
Brenda Farrell from Knoxville, Tennessee, with a 29-year-old son. I found that it's helpful to download the brochures from the DSF website and take a brochure with you to the new doctors, not just to the new neurologist, adult neurologist, but to any specialist. Even my own psychiatrist was interested when I told her my son had Dravet syndrome and wanted to know about it. So printing those brochures and sharing them with any medical professionals that you come in contact with is a great help.
Resources. Thank you. Yeah, no doubt, it's a team effort. I really think that's exactly true. So the foundations, like the organization, really is very important. And definitely don't feel bad. Sometimes it's like, I'm going to go into the doctor's office and put them on the spot. They're going to be defensive. They're the doctor. They know best. Bullshit. Bullshit. Nonsense. If they're really like that, screw them, man. Whatever. If they're really like that, whatever. I hate to say it like that, but basically, this is about your loved one and the one you care for. And I really think it's all about messaging. I hate to say it like that. It's about messaging. And really, is it really fair that you as a caregiver or family member should have to lay the dove of life and all that out to them? I think I do. I do think there's some reality of what it is, because unfortunately there's ignorance. In the healthcare field for developmental disabilities, they don't really know. Just like it is, I keep going back to Ukraine. Ignorance, man. Ignorance. They don't really know that people with developmental disabilities have any value at all. And I think in the healthcare training, we just don't get it. I'm an adult neurologist. We're just not getting it in medical schools. I'm not really getting it in my neurology training. We're not. Whatever we learn in pediatric neurology, we only get a few months in our training is nothing. We get like nothing. We're put out in the world of adult neurology care without really appreciating developmental disability. So the whole transition of care is challenging, because because the adult neurologists aren't getting it. They're just not getting it. So again, advocacy and families bringing information and support, holding the hand out of please help, we respect you, we'll learn some of the journey together, whatever message you do, you got to do it. Any other questions?
I've got a couple years yet until I am going to get to this point, but I'm just trying to learn and soak in as much as I can. Right now, our neurologist is, he does a lot of what a PCP would normally do. I don't know if that's like that for any of y'all, but our neurologist, I mean, he orders blood tests and we got a G button just recently, and that was ordered by him. And it seems like we see our neurologist more, and maybe that's just me, I don't know, but did you take care of like Dawn's, were you more of like a PCP or primary for her as well, or do you work with the primary closely? I mean, my primary and neurologist work together, but our neurologist is the one that he is very proactive in helping me. And not that my PCP isn't, but my PCP doesn't understand Dravet. So,
I think the difficulty of the adult neurologist acting as a primary care doctor is challenging because we're not trained that way. So we're not really basically trained on all the nuances that a primary care doctor would need to do in terms of social, health maintenance, well checks, all the kind of things we do. So I think in a way it almost puts the neurologist in a bind for them, in a bind that they're trying to, I mean, maybe it's wonderful that they're doing what they're doing for the right reasons, to do it that way. But I think to think of that generally for most adult neurologists around the country or around the world, I just can't imagine that. I just think, and the one thing I would even relate to that, more relate to primary care, is behavioral management. I think that would be the one thing that basically becomes more up of an issue of someone with an intellectual developmental disability coming into my practice who has not only epilepsy, which is what I treat, but also has autistic behavior or ADHD, and that type of care is provided medically by the pediatric neurologist. And then the adult neurologist does not do that. They particularly care for the epilepsy and not the behavioral issues. So I see that as more of an issue, more than the assuming of primary care responsibilities. The blood testing, to me, that would become part of what we would do anyway as a neurologist, because people on medication need to have their kidneys and blood tests monitored. But I definitely feel it's difficult, and I think it's also I would say, let the primary doctor off of. They need to also take the responsibility, and maybe I wouldn't say they're spoiled, but maybe they would allow the pediatric neurologist to do it. So I think the transition of care really, I think for the most part, should really be looked at of who really does assume the responsibility, has the knowledge, the expertise, and I definitely think, at least on the adult side, the primary care doctors have to take responsibility, just like the adult neurologist has to take the responsibility and learn to grow to feel comfortable with it. Of course, it's easier said than done. I mean, this whole philosophical conversation. It's they should. Oh yes, okay, they'll do it. No, but and then the other challenge is the communication. Because I was just leaving a talk with some of our colleagues about transition of care, is that like transition clinic, we're all going to be together, and all the specialists are going to be like the primary care, the psychiatrists, the social services, we're all going to talk together and holistically in a multidisciplinary fashion. We're going to all have a team, and we're all going to talk about it, and we're all going to be on the same page, and we're all going to do the right thing. And doesn't that sound great? I mean, doesn't that sound like what you would want for best care? Of course. But is that really what happens in Middle America? Does that happen in every city and town and township around the country? Basically, it's siloed care. I mean, really, basically, it's siloed. We have a specialist this, and you have a person that does this, and do they communicate? And I certainly think in anyone here who is supporting caring for someone with Dravet who does have complex health issues, you get that. You get that, the importance of need. So what I do in my own way of being where do I describe what I do? Basically, trying to break down the barriers of communication is almost force the hand of the other doctors to almost communicate, because almost like innately they're not used to that. They're not used to reaching out or spending notes to each other. But basically, the United States healthcare system isn't that great. I mean, it's really not that great for adults, especially those with intellectual developmental disability. No, I don't know if I quite answer your question, but basically, I just don't know that the adult neurologist would be the one that is qualified to be able to provide that level of holistic support. I'm just not really sure. and expecting that for all neurologists. I don't think that's going to happen, truthfully. I hate to say that.
Oh, I mean, I didn't mean you do it. I just
No, in general.
He's the one. Our neurologist is the one that knows what is going on with Dravet, like the issues that we're dealing with. So
Right.
he will refer us to, if you will, someone else. That's what I meant by that. Not that they do it. It's just our neurologist knows more right now about what is going on with our son than our PCP does. I mean, they work together, of course. I guess I asked the question wrong. They work together.
Right.
And then my other question was, do you see a lot of adults with like G-button? Because you said dietary and that Dawn had to get a feeding tube. Do you treat very many with G-buttons already or feeding tubes?
I really don't. I mean,
Okay.
that is still, it is, from the pediatric world, certainly nutritional supplementation or ketogenic type diet certainly have been more in the world on the pediatric side. And it really isn't much on the adult side. So that wasn't for Dawn in particular when I started caring for her in her early 30s. Her nutritional needs really weren't as much addressed. Her feeding tube was really placed basically because she progressed in her Dravet and she developed more swallowing dysfunction, but it wasn't really more of the management of a regulated diet, specifically like ketogenic or such like that. And that's another aspect of what the adult neurologist may do or not do as compared to pediatrics. But definitely going, just one quick comment, probably over my time, is the resources, if that's what you're saying, that the adult neurologist who knows enough to know enough of what to do in terms of giving resources out. Well, I'm going to give a resource to say you can contact the Dravet Syndrome Foundation or other foundation in the community. Definitely. I definitely feel very strongly as someone who's an advocate for my patients, that is my responsibility to advocate for them and provide practices or suggestions. And I do specialize in aging. My other forte, as I was mentioning, is aging and dementia. So I would have them contact the local aging organizations or Alzheimer's associations or OTs or PTs or speech organizations or therapies that they need. That is true. That is absolutely coming from me rather than defer back to the primary care doctor. So I do understand your question. Yeah, thank you.
So we just have one more question, which is kind of a follow-up. We're going to be quick because we don't want to go over too much time.
Yeah, hi. I have a 27-year-old daughter with Dravet, and we transitioned to adult care. I have I think, wonderful neurologist, but my question is a little bit more specific regarding the things that you noted with Dawn with the, progressive gait problems and motor issues. Like those are neurologic, musculoskeletal, and are there specific things that you would recommend to an adult neurologist in terms of monitoring? And I know interventions are unclear at this time in terms of what will be recommended, but are there specific things that you would suggest an adult neurologist do with their aging patient?
That's a great question. I think one of the most important things to do with an adult neurologist, it depends on what stage of life they're beginning to care for the person, is what were they like? I mean, to know the person. Because if you don't, I think the intrinsic bias of any physician or anyone, maybe in particular, is someone with developmental disability comes their way in their office and they see them talking a certain way, walking a certain way, acting a certain way, and thinking this is who they are and this is so-called normal for them, without appreciating that maybe that's not normal for them, that maybe a change has occurred. So I think the most important thing in terms of addressing even that question of change is to know wholeheartedly of what were they like when they were at their best. And that would be by the information by the family members, photographs, videos, and really know that this is different from my loved one. This is really not. And so I think that's the most important thing, is to address the person and understand who they really were before and what they're now happening over some period of time, whether that's abruptly or more progressively, it's different. Because the neurologists may not know, they may not even appreciate the nuances of change. So I think number one is getting the best performance of the person, and then basically the person that's following them over time know that there's certain syndromes like Dravet and others that might change. And so that became apparent with Dawn. She used to walk, she used to run, she used to communicate more, and then as she got in her 30s and 40s, she again slowly began to lose skills. So I'm like, what the hell? What's going on with her? She did not have a Dravet diagnosis. So I did my workup. I did my MRI. MRIs, I did blood tests, I did EEGs. I mean, I did traditional things, look for change in anyone that could be musculoskeletal etiology. This is not, I couldn't find any reason, and I went back to what's really wrong with why is Dawn Dawn? Genetic. So she did not have a formal diagnosis. So then I, kicked me in the head, didn't take me that long, that I really need to do a genetic assessment. And that's basically what it took. So basically it takes the understanding what their baseline normal was before, knowing them over time, following them, but definitely trusting the caregiver. I think the caregiver is number one, again, this is no shock to the families and people in the audience, is trust that they know the person, that they themselves appreciate the changes that are going on, and the neurologist may not really be as sensitized to that, and just to really keep pushing. This is different, why? And never assume that maybe there's nothing you can do about it. And I think the fait accompli would be also a bad thing. Oh, they got a developmental disability, this is their fate in life, there's nothing you could do. Why do a test? Why do an MRI? Why do genetics? So one thing that we do is we also fight to test genetics in older people. So what we do is, right now there's a fait accompli that the adult neurologist may have someone with developmental disabilities in their 30s, 40s, and 50s, and they'd never had a genetic assessment more recent about why should they do it. So we have to go through insurance companies and fight for those issues for the adult neurologist. Really, why should they even test people? Because they might feel there's no reason for it. It's not going to change anything. So I mean, if that answers all your question, but it kind of gives you some. Well, certainly. I mean, the other people. There's always like orthopedics, certainly. There's physical medicine, rehab. I mean, because you're looking for other reasons. So other physicians that might care for someone, like anyone. If you're like limping or something like that, or walking, who do you go to? You could see other physicians that might look for the other reasons for it. But I wouldn't really say there's like especially neurologist on the adult side. Unfortunately, there's really not. But there are the specialties, again, like orthopedics, because you might have a back problem, you might have a hip problem that might make you walk, and it might be. I mean, like all of us, I'm now 6 years old, I'm now limping a little bit myself. But basically, it's the reality of age does change. So just because you're getting older doesn't mean it's Dravet, and Dravet is a syndrome with progression. It might be Dravet now, the individual Dravet now has a bad back or bad hip or an ankle or such other things. So there are other reasons for change, and that's really where, and the person with Dravet may not be able to vocalize to the person, oh gosh, I'm walking away because my back really hurts and walking bad. So it might be difficult to be able to do that. So you have to really think outside the box in some respects in some of that changing. But I definitely feel the neurologist would be the central individual who would be the one, but it may not always be the case that the neurologist takes it up and does that. But I think the neurologist would be central, I think. Okay, thank you all.
Okay, thank you.